Thank you, Dr. Harold. Our next speaker will be Dr. Shmuel Banai from Tel-Aviv Sourasky Medical Center here in Tel Aviv. And Dr. Banai will speak on the therapeutic options in patients with refractory angina. Welcome.
Thank you, Dr. Gara. Thank you, Yossi Rosenman. It's a great honor for me to speak here today, and I'm going to try and show you some new data regarding the therapeutic options of patients with refractory angina. This is my disclosure. I'm the medical director of Neovasc, the company developing the coronary sinus reducer and the Tiara transcatheter mitral valve. According to the European Society of Cardiology, refractory angina is a chronic condition characterized by angina caused by coronary insufficiency in the setting of coronary artery disease, which cannot be controlled by a combination of medical therapy, angioplasty, and bypass surgery, where the presence of reversible myocardial ischemia has been clinically established to be the cause of the symptoms. As the population ages and mortality from coronary artery disease decreases, a growing number of patients with severe coronary artery disease continue to experience angina, which is not amenable to surgical or percutaneous coronary revascularization despite excellent medical therapy. These patients are often labeled as no-option patients with end-stage coronary artery disease. Data derived from cardiac cath lab registry show that about 6 to 12% of patients referred to angiography with evidence of ischemia were ineligible for traditional revascularization. This rate would imply to 100 to 200,000 new patients identified per year in the USA alone. Anatomic reasons which preclude traditional revascularization include diffuse distal coronary artery disease, collateral-dependent myocardium, multiple coronary restenosis, chronic total occlusion, degenerated vein grafts, poor distal target for bypass, lack of conduit due to prior bypass surgery, and significant comorbidities. Patients suffering from refractory angina report a poor quality of life and high level of depression and anxiety due to their debilitating disease. Currently, treatment options for this growing patient group are limited to traditional anti-anginal therapy and secondary risk factor modification. Surprisingly, the long-term survival of patients with refractory angina is pretty good. This graph is taken from a paper published 2 months ago by Tim Henry in the European Journal of Cardiology, in European Heart Journal, and it shows the graph of survival care of 1,200 patients with refractory angina. Sorry. As we can see, over 70% of these patients can expect to survive 9 years from the time of diagnosis. So because long-term mortality in these patients is low, therapy should focus on chest pain relief and improve quality of life. Alternative treatment options for refractory angina today, if I can list them, are education, rehabilitation, cognitive behavioral therapy, spinal cord stimulation, thoracoscopic sympathectomy, myocardial angiogenesis by protein, gene, or stem cell therapy, enhanced external counterpulsation, EECP, and transmyocardial laser revascularization. Let's discuss in a few minutes few of these, the most important alternative treatment option. Enhanced external counterpulsation is an FDA-approved non-invasive treatment for chronic stable angina, which has been used for the past 2 decades. Several publications support its efficacy and show that EECP has been associated with improved exercise tolerance and myocardial perfusion. This paper was published in 1999. It's a multi-center study of enhanced external counterpulsation, the MUST EECP. Patients were given 34 hours of active or inactive counterpulsation over a period of 4 to 7 weeks, and the conclusions were that EECP reduced angina and extended time to exercise-induced ischemia in patients with symptomatic coronary artery disease, and that the treatment was relatively well tolerated and free of limiting side effects in most patients. Again, this was published in 1999. What about laser myocardial revascularization? This is a paper published by Marty Leon and Ron Kornowski in JACC 2005, a blinded randomized placebo-controlled trial of percutaneous laser myocardial revascularization to improve angina in this symptomatic patient with severe coronary artery disease. It shows the treatment with percutaneous myocardial laser revascularization provide no benefit beyond that of a similar sham procedure in patients blinded to the treatment status. By the way, the placebo effect in this trial was about 30%. Spinal cord stimulation for intractable angina. Here we talk about a pulse generator which is placed in a subcostal pocket and connected to an electrode lead placed in the epidural space in the T1 level. The electrode is inserted by direct puncture under fluoroscopy, and the final position is determined by a sensation of paresthesias of the thoracic area, sometimes also including left arm corresponding the area of the anginal pain. This paper was also published in JACC in 1994. Efficacy of spinal cord stimulation as adjuvant therapy for intractable angina pectoris, a prospective randomized clinical study, shows that spinal cord stimulation significantly improves exercise capacity, and quality of life, and the mechanism by which spinal cord stimulation acts is really not known. Whether effective or not, it is a fact that none of these alternative therapeutic options for refractory angina has become a standard of care, and none is routinely used in our clinical practice. The coronary sinus reducer is an emerging new option for the treatment of patients with refractory angina who are not candidates for revascularization. This is an hourglass-shaped stent implanted in the coronary sinus, creates control narrowing to modulate flow and elevate coronary sinus pressure. Coronary sinus pressure elevation increases endothelial perfusion, providing relief of ischemia and angina. This happens only in the setting of coronary artery disease. It doesn't happen in normal patients with normal coronary arteries. Increased coronary sinus pressure by the reducer lead to redistribution of collateral blood flow from non-ischemic to ischemic territories of the myocardium, and it causes redistribution of arterial blood from the subepicardium to the subendocardium, with normalization of the abnormal endocardial to epicardial blood flow ratios. This is a CT angiography taken 1 year after implantation of the reducer. The mechanism of action, You can see here the coronary sinus going into the atrium, and you see the narrowing at the center, and again here. The center of the reducer is always in the diameter of 3 millimeters. The implantation itself is very easy and straightforward. Through a vein stick in the internal jugular vein, you get in a diagnostic multipurpose catheter into the coronary sinus through the right atrium, and you take an angiography of the coronary sinus. Then you take QCA measurements of the site where you decide to implant, and we usually implant it right after this bend here, this area, avoiding side branches. The implantation itself is through a guiding catheter, inflating the balloon with the reducer, really very simple and straightforward. And right after the implantation, you can see again the diagnostic multi-purpose catheter, and you see the reducer here, slight oversizing on both ends, and 3 mm narrowing at the center. First-in-man data and registry data of the reducer show that the coronary sinus reducer implantation in patients with refractory angina is straightforward, feasible, and safe. Clinical improvement was observed in almost all patients 6 months to 3 years post-reducer implantation, with a significant reduction of CCS class angina score. This is a paper published 2 months ago by Dr. Koenigstein, concluding that the reducer implantation as a treatment for no-option refractory angina patient showed a significant improvement in angina severity as well as in the objective parameters of ischemia. The results of the randomized placebo-controlled trial will address the possible placebo effect and will hopefully establish the reducer as a device-based therapy for refractory angina. So here are now the results of the COSIRA trial, which is a randomized double-blind sham-controlled multi-center clinical trial. The aim of the trial was to examine whether implantation of the reducer could effectively and safely improve angina symptoms in patients with obstructive coronary artery disease, angina class 3 and 4, and concomitant evidence of reversible myocardial ischemia. The study was a prospective randomized double-blind sham-controlled multi-center clinical trial in 11 clinical centers, 104 patients. Patients and physicians assessing the CCS class and quality of life questionnaire were blinded to the treatment throughout the study period. So were the Dobutamine stress echo and exercise stress test core lab were blinded to the treatment groups. These are the 11 sites, 2 sites in Belgium. Stefan Verhey from Belgium was the European PI, 2 sites in Canada, in Montreal and Ottawa Heart Institute, 4 sites in the United Kingdom, 1 in Sweden, 1 in the Netherlands, and 1 in Denmark. 166 patients were screened, and a total of 104 patients were enrolled and randomized, 52 to the reducer group and 52 to the sham control group. In 2 patients, we were not able to implant the reducer. Nevertheless, the final analysis was of 52 and 52 by intention to treat analysis. The primary efficacy endpoint was an improvement of 2 or more classes from baseline to 6 months. And the secondary efficacy endpoint will change in the following ischemia parameters from baseline to 6 months, an improvement of 1 or more classes of CCS, Dobutamine stress echo wall motion score index, Seattle Angina questionnaire for quality of life, and exercise test parameters. Inclusion criteria included symptomatic coronary artery disease with chronic refractory angina grade 3 and 4, despite maximal or optimal medical therapy for at least 30 days, documented evidence of reversible myocardial ischemia by Dobutamine stress echo, ejection fraction higher than 25%, and only patients deemed unsuitable for coronary revascularization were eligible to participate in the study. Exclusion criteria included recent revascularization, recent acute coronary syndrome, patient with pacemaker leads in the coronary sinus or in the right atrium, and patients with high right atrial pressure and with abnormal or very large coronary sinus. The basic clinical characteristics are here in this table in front of you. The only difference between the groups were that the reducer patients were a little older. And the results. 35% of the patients in the reducer group versus only 15% in the sham control group improved by 2 2 or more CCS class, and this was the primary endpoint. This was statistically significant. Improvement of 1 or more CCS class, 71% of the patient in the reducer group versus 42% in the sham control group improved. This shows a 42% placebo effect, and in spite of this huge placebo effect on the sham control group, we still see a further improvement, a much higher improvement in the reducer group, and the change between the groups is statistically significant. If we look at the mean CCS class in the reducer group and the sham control group, we can see that both groups, the reducer and the sham control, improved, but the degree of improvement in the reducer group was significantly better than in the sham control group. And if we look now at the distribution of CCS class, we can see that at baseline, 100% of the patients were in class 3 and 4, and after 6 months, there was more even. The patients were more evenly separated spread between the CCS class, but we see more patients from the reducer group in class 1 and 2 and less patients in the reducer group in class 3 and 4, and this was also statistically significant. The secondary endpoint in this study were not powered for statistical significance. Nevertheless, we can see here in the quality of life questionnaire that quality of life was improved 2.75-fold better in the reducer group. The same with anginal stability and angina frequency. It didn't reach statistical significance, but we have 2.5-fold improvement and 1.5 improvement in the reducer group. Stress test parameters, we can see that total exercise duration improved in the reducer group by almost 1 minute, 59 seconds, and only 3 seconds in the control group, and the same, and it was 13-fold improvement for the reducer group. Dobutamine stress echo, if we look at the modified left coronary artery wall motion score index, we see that there was an improvement of 13% in the reducer group and only 2.3% in the sham control group. Again, this was not powered in this study for statistical significance. Nevertheless, we see the trend clearly. There were any safety issues. There were 2 MIs and no death in the reducer group, and 1 death and 3 MIs in the sham control group. All the major adverse events were adjudicated by the clinical event committee as not related to the device or the index procedure. So in summary, the COSIRA trial evaluated the coronary sinus reducer as a new therapy for patients with refractory angina. Reducer implantation was significantly better than the sham intervention to improve angina symptoms in patients with advanced coronary artery disease unsuitable for revascularization and treated with optimal medical therapy. The improvement of 2 or more CCS classes, which were the primary endpoints, occurred 2.3 times more frequently in the reducer group, demonstrating a clinically meaningful difference. Although underpowered for the pre-specified secondary outcome, we observed concordant improvement from baseline to 6 months follow-up in the reducer group in 1 or more class angina class improvement, change in quality of life, angina stability and angina frequency scored by Seattle Angina Questionnaire, change in total exercise duration, change in time to 1 millimeter ST depression, and change in LV wall motion score index. The conclusion and clinical implication of the COSIRA trial is that among patients suffering from severe disabling angina pectoris, this double-blind randomized sham-controlled trial demonstrated safety and efficacy of the reducer in improving symptoms of angina and improving quality of life. Based on this finding, we believe that percutaneous transvenous implantation of the reducer is a safe and effective treatment for patients with refractory angina. Thank you very much.